Yes, so the abstract was examining the association between endometriosis and preeclampsia and eclampsia in Black women. The abstract, of course, is notable because there's critical gaps in maternal health research. Endometriosis affects approximately 10% of reproductive age women, yet Black women are 50% less likely to be diagnosed. On the other hand, preeclampsia and eclampsia are notorious for having the highest rates in Black women in the U.S., with Black women having the highest maternal mortality rates from it in comparison to any other ethnic group. So there has been emerging evidence that suggests that preeclampsia and for hypertensive disorders of pregnancy like preeclampsia and eclampsia and endometriosis share an overlapping immunologic and vascular pathway. This association is, even though it's biological, there's a biological plausibility with it. There's no known information or research regarding its intersection with Black women. So the ultimate goal of the scoping review that was conducted was to determine if there was any literature that was available that actually race stratified the results to determine if endometriosis is associated with preeclampsia and eclampsia, specifically in the Black population. And what we found out was there was absolutely no studies that were conducted within the U.S. 3 studies that were conducted in the U.S. actually collected race data, but did not stratify results. So the data was absolutely meaningless to us in terms of determining if endometriosis has an impact in the development of preeclampsia and how that affects Black women. So ultimately, our findings call for more race stratified results as well as more research that's actually inclusive, to include all representation, to ensure that we are capturing the information that is actually important to us in order to be better clinicians in the future, as well as ensuring that we can actually determine if there's actual causality or actual causation between endometriosis and preeclampsia. Yes, it basically tells us that just because there's no evidence doesn't mean that there's no risk factors. It just means that there's more presence of neglect. Black women are underrepresented in research, and they've been notorious for being underrepresented. So ultimately, it provides us more information that we need to ensure that Black women are Black women are captured. Meaning, if it's oversampling of Black women in specific populations, in terms of research, that we need to do that in order to ensure that they're actually being included in data. Because if we have no data to represent them, ultimately we don't have the best ways to actually treat first of all, diagnose and treat them, and become in order to improve their health outcomes. So ultimately, this type of research helps us capture the fact that there's no data that is available for Black women, and therefore the next steps is actually to capture more data in regards to them. So as of right now, there's no guidelines that suggest that if you have endometriosis, then we need to treat potentially for preeclampsia because, like I mentioned, there's no causation as of now. We just know there's a biological plausibility. However, clinicians to start, particularly primary care clinicians, they're the people that are the first in line in terms of seeing the patients first, oftentimes before actual OB-GYN. So ultimately, we don't want to scare our patients and we say that if you have endometriosis, then you're more likely to be diagnosed with preeclampsia. But we want to tell them that there have been systematic reviews that suggest that there is an that they share overlapping mechanisms. And therefore, we should start treating our patients in terms of patients that we potentially think have endometriosis clinically. So if a patient comes in with severe chronic pelvic pain, bad menstrual pain as well, we should start clinically diagnosing them with endometriosis, and then potentially looking at ways that this could further implicate the risk of developing preeclampsia in the future. Whether it's we need to start monitoring their blood pressures sooner than later, developing a plan for if they plan to have kids in the future, or if they've had history of having children, knowing their maternal history. If they desired children in the future, then developing a plan so when they do decide to have children, looking at ways that we can get maternal fetal medicine involved. These are steps that we need to take to be more proactive. Just because we don't have perfect evidence doesn't mean that we should not treat our patients with the respect and care that they need, and also develop a game plan to prevent risks from happening. With Black women less likely to be diagnosed, like I mentioned, they're 50% less likely to be diagnosed. That just tells us that their data is not captured, and if their data is not captured, then we have no data that represents them. And so if we have no data that represents them, then in the long term, when they're actually are desiring children and then actually getting pregnant, we have no data that shows that there's a potential risk of you having endometriosis with then developing preeclampsia or any other hypertensive disorder of pregnancy. So it basically prevents us from actually understanding truly if there's actual causation. So therefore, with Black women not being diagnosed, they're clinically and outside of the clinical world, they're invisible to the world. And so therefore, we need more data in order to capture the actual true outcomes. If a patient is at risk for developing preeclampsia, is it as a result of potential inflammatory conditions such as endometriosis? But as of right now, because Black women are less likely to be diagnosed, they're ultimately invisible in our data sets.